So I'm going to talk about violence risk today. I think it's moving by itself. Hang on. I'm going to talk about violence risk. It is a multi-hour topic, so I'm going to go fast. I'll probably just touch on a few of the slides, but you will have the whole slide set. And if I get to the end and there's still time, you have questions about one of the slides, I can certainly go back to the slides. So, no disclosures. I do want to acknowledge some content from Dr. Resnick, who's probably the most known international speaker on the topic of violence, and then another physician, Dr. Khan. So let's take this, just you can think about this for a moment. What is the best predictor? Darn, it's moving by itself, and I do not know why. Hang on.
Doug, did you use this? Did you use this template from something else?
Probably.
It might have some automatic timings in it.
Okay.
You would need to stop, otherwise, you'd have to remove the timings. Otherwise, it might just keep going on its own and you will argue with it the whole time.
Okay. Well, I'm not sure how to remove it, so I'll just argue.
Okay.
All right, so we'll do this. So what is the best predictor of violence? And I'll let you look at this for a moment. Um, Obviously, one of these is a little bit tongue in cheek on there, but um, and the answer is actually none of the above. And the reason it's none of the above is because we actually are not good at predicting violence. We can assess violence risk, and the reason for this is that although we hear about violence a lot in the news, and we know that it happens in hospital settings and emergency departments and sometimes psychiatric units and the like, not to mention crime on the street and other types of violence, the reality is it's very low. It's a very small frequency event. And as a result of that, it's very hard to predict. And in fact, there's a famous U.S. Supreme Court case where they argued about the expert witness testifying about violence risk, and the Supreme Court justice said something to the effect of, well, psychiatrists are not wrong all the time about predicting violence, just most of the time. And they allowed the testimony. So that was, in my mind, a funny sort of way of looking at this from the judicial perspective. So we can learn to assess it. I want to touch on that today, again briefly, because that's a whole nother series of lectures and on various actuarial instruments and things of that nature. But at least I'll give you the risk factors and a few other neurological and nurturing factors here. Let's start with, why are people violent? This says I had to bite him once, but now I always get a great table. And the point of this is that we do sometimes be violent to set a standard, to say I'm not going to be messed with, or to make an appointment, or to obtain dominance over somebody. Some of the best action movies are based on this top one here, to punish others, right? So there's a revenge, and of course, the person who gets wronged magically happens to have been trained in extreme special forces somewhere in the past. I'm thinking of several Liam Neeson movies, and the net result is now they come out and it's a great action film, right? You got to suspend your disbelief a bit, but it's a great escape, which is why many people go watch movies anyway. It may be that you have a sense that someone's taking your freedom away. A group of people surround you. Maybe law enforcement puts hands on you. You're having this threat of freedom being taken away, and you may react to that as a human animal. There's carryover aggression. You white knuckle it all day. You can't stand your boss, but you're not going to yell at your boss because you need money to live. You go home and you punch the wall, right? Sort of carryover aggression. Worse yet, you hit the pet, or you hit your significant other, what have you. So there's that carryover aggression is also a problem. And I'll mention a few others here. I'm not going to do them all today. This one, here's the first one: establishing reputation. When I used to moonlight in the Ohio prison system, there was way less violence than the movies make it sound like. But when it occurred, it was generally a person more my size reacting to somebody much bigger. I was only in a male prison, so a bigger male, let's say, might decide to mess with somebody my size. And that person, my person, pretend it's me. I would fight back anyway, likely going to get hurt more than the bigger person, but we're both going to get hurt, and it sets the tone. Don't mess with me. It's not going to be easy, right? So I'm establishing this reputation and so forth. Protection, right? We actually have very strong laws. Ohio is one of the strongest in the country with the new stand your relatively new stand your ground law. You're allowed to protect yourself, your loved ones, your property, including up to and including shooting and killing somebody. And you know, it's obvious they're generally fairly logical. If they're at your home, if they're in your house, you can shoot and kill them. If they're running away down the street, you cannot chase them down and shoot them in the back. Right? So we've got some rules around when are humans allowed to be violent, mostly to say we understand that humans are violent. As a society, all societies across the world understand that humans will be violent under certain circumstances, and we actually allow it in many, many cultures under certain circumstances, not always the same ones. Wilding is kind of group violence. People need to belong. You want to belong to a group. The only group you can belong to in your area happens to be a gang. That gang may have a rite of passage around doing something violent to join the gang, or in fact, being in the gang requires you to be violent on a regular basis. You may be violent because of that. And then, of course, for our topic, integrated care around mental health, if you have impaired thinking or judgment, that, of course, may alter your perception. You may believe that you are acting violently to fulfill one of these other ones that I had on these first two slides, right? Maybe you think they're attacking you, you're going to defend yourself. Maybe you think you're protecting yourself or your loved one, right? So, or maybe you believe you're Jesus and you think you're shooting the devil, and of course that would make sense in that rational mind, even though you're in a delusional state, right? So this impaired thinking or judgment and reality testing even can be part of the violence. So most of us think of violence this way, sadly, right? When it hits the news, mass shootings, by the way, originally were defined as a shooting where four or more people were actually killed. They did readjust that at the federal level to three or more people. And so based on that, Mother Jones, a journal, magazine, they put this out. And actually, this bottom part is incorrect. I updated it past 2018 to 2024, but 151 that met that criterion of three actual killed. And of course, these make the news and the headlines for weeks. They get into gun control issue, get lots of controversy because it's a very stressful for our society to realize that these things occur. But the reality is that most violence is at a lower level, right? It's domestic violence, it's getting angry and yelling, and other types of violence that we don't rise to the level of the news. And that's really what we're talking about really today is all these ranges of violence. So there used to be thought of two types of violence: affective or emotional violence. And this is the fight, flight, or freeze, right? A giant bear jumps in the room where Nicole's sitting. She's either going to fight, she's going to run, or sadly, many humans freeze. Not very adaptive if the bear is about to get you, right? And of course, our law enforcement and our military in particular are trained a lot, so at very least they won't freeze in a certain circumstance, right? So they're being shot at or they're trying to protect a citizen if they're a law enforcement from another citizen. Freezing won't be helpful. So they're going to either fight or flee or and maybe help the person flee. That's more of an emotional, autonomic nervous system type response. Imagine a cat that you corner in the room where you're at, and it clearly is trapped. It can't get past you. It's going to start to hiss. It's going to scratch out at the air. That would be an emotional or affective response. Take the same cat, and assuming you have a window, well, I do today, sitting at home. So you look out the window and you see a cat walking very slowly across the grass. If you see the whole scene, you realize there's a bird on a low branch. That's a predatory, probably for a cat, very much instinctive or innate, built in. But humans, of course, can also stalk. They can plan violence in certain circumstances. And that's a different type of violence where, again, if your judgment's off or your reality testing's off, it may be driven by that, but you're still capable, the rest of your brain's working fine. You can plan out actions to potentially harm somebody in that motion. The newer type of violence really started with MySpace. If any of you remember that, predates Facebook and some of the other ones. And unfortunately, it showed a version of bullying. Of course, bullying was already in existence for years, but it showed a new version of this social violence of going after people, and then unfortunately others can glom onto that and really cause damage emotionally to a person, up to unfortunately to the point where people may die by suicide over this type of social violence. And we're still trying to understand. There's a lot of research ongoing. They have tied some of this in research to testosterone, including in women. If they have a slightly higher level of testosterone, that may be the group, the women that actually do more of this. And so that's a new one, probably a whole nother topic someday, but it's ongoing research now. So let's be a little science-based here to start. So neurobiological basis. So we have a bunch of brain structures. We're doing a lot of research on these. So the two big structures that get looked at from the cognitive perspective, and then I'll do emotional in the next slide, next two slides, are orbital cortex of the brain and then the anterior temporal lobe. These two parts of the brain, when they're both active, tend to help us to consider whether or not to be violent in that moment. And if they're in balance, we tend to do a good job inhibiting ourselves from that violence and not becoming violent. But when they're out of balance in some fashion, or they're put upon by the more emotional aspects of the brain, that will increase our potential. Again, potential because it's not definitive that you're going to be violent. That's why it's always a risk. It's a factor, risk factor type analysis. The limbic system, mostly the amygdala we talk about, that has the most research on it. That's our deeper animal part of the brain. That's kind of how I refer to it. And that part of the brain is very much tied then to aggression, especially if these first two parts of the brain aren't able to inhibit the emotional response that occurs in that amygdala. So in the amygdala, they've done all sorts of studies. The poor mice and rats tend to be the first subjects of these, but I'll use humans here just for time's sake. There is a syndrome where they need to remove the temporal lobes in the human brain. They end up calling that a Kluver-Bucy for the two people who discovered this. And it basically, by getting rid of that, or getting rid of just the amygdala, the person becomes very docile, very tame. And so we know that with those parts lead to aggression. If you get rid of them or knock them out in some way, you have less aggression. Similarly, if you stimulate the amygdala with electrical stimulation, and we're usually talking tiny amounts of electricity, by the way, it will create all sorts of aggressive behavior. As a forensic psychiatrist, I'm very interested in this 1966 case. This was Charles Whitman. He was the Texas Tower sniper at University Austin, Texas, and out of character for him, he went up into this tower and started shooting and killing people. Eventually, of course, they got him, they killed him, and the net result was they did an autopsy. It turned out he had a tumor pressing on his amygdala. It was not sudden mental illness. So even back in 1966, which probably is older than most of us here on the list, I mean that even then they were able to see that something like a brain tumor could lead to aggression because of what it affected in the actual brain. And then more close to home for a lot of us here on this today is serotonin. There's other neurotransmitters. For time's sake, I'll mention serotonin here. We know that low levels of serotonin are associated with increased aggression, increased suicidality, OCD. It generally gets tied to obsessive compulsive disorder, and other things like anxiety and depression, all related to low levels of serotonin. But for today, aggression very much associated with low levels of serotonin. And it also increases impulsivity, which actually, impulsivity is one of the risk factors that gets assessed for looking at potential violence in the future. So I won't go through all this. This gives you a little bit more about some studies they've done with mice and so forth around serotonin. So that was biology. Let me talk about nurture. So it's nature and nurture. Nature generally seen as the biology, the genetics, and then of course nurture. So I mentioned earlier animals. We forget most hours and most days that we are animals. And we are also social animals. And we need parental bonding, lots of studies about that. We need to belong. As I mentioned, even in if the only group you're going to belong to is a violent group, we probably will try to belong to that as opposed to being alone. We need social supports. We do much better when appropriate behaviors are modeled for us by those who nurture us as we grow up. That's cultural. There are some cultures where things are more modeled than others, and so forth. We need daily structure. We need purpose. All these things are very important. With any of these out of the equation, that does increase the risk that somebody may actually be violent. So that's another concern for us. Here's a nurture, kind of sort of a joke nurture. Some kids at school called you a feminist mom, but I punched them out. Now, how these two parents respond to that will make a difference, right? If the father looks up from his newspaper and says, "Good job, honey. Let me teach you some new martial arts moves over the next week." That's one reaction. The mother or the father could say, "Well, hold on. Whoa, you did what? You punched somebody?" Right? And let's have a conversation about was that good judgment? What else happened? Right? So and you can imagine a whole range of responses by parents to this event, assuming that the it looks like an outfit as a daughter, who knows? But it could be a son, comes home with this story. Okay. So again, it's probably this combination of nature and nurture. In the wrong aspects, bad aspects, they end up doing this. There are other genetics here, like the monoamine oxidase A. It gets associated with some of this. Brain damage, no doubt, as I mentioned. Again, we're going real fast today for time's sake. Certain areas get damaged, can increase the risk of violence, especially that frontal lobe that tends to inhibit our violent, allows us to follow the laws. And although I think most of our brains are a little damaged in the speeding part, where we seem to still speed while we're driving, but I'm not sure. Maybe that's a different part of the brain. But mostly most humans are inhibited from breaking laws and so forth. Trauma, right? A whole nother lecture again. We know that trauma, especially in early childhood, up through the age of 6 in particular, really has a huge effect on us as far as our emotional stability, mental illness, as well as physical illness. That was all the ACE study discoveries that we didn't realize how much integrated care, how much that was going to affect us in the physical arena as we get older. And then, of course, poor parental bonding, huge issue, harder to study, but it does get studied, and they do it both on fathers, they do it on mothers, and now they'll do it on same-sex couples that are raising children. There's a lot of studies ongoing to show, and in all cases, better bonding, better outcomes is the bottom line. It's pretty straightforward there. And then again, we can't call these causative. We can't therefore say we can predict it definitively because all the studies are ultimately correlational. Way too many factors, I think, to study well. I'd be remiss if I didn't mention DSM-4 and now 5. We have impulse control disorders that are listed here. Again, I won't go into these today. That's a whole nother topic, but these are the ones that are now listed in the DSM-5. Intermittent explosive disorder, kleptomania, which is shoplifting, pyromania, which is fire setting, oppositional defiant, and conduct disorders. These get put into this category. Again, lots of research trying to understand these. They're relatively low base rates, although when you move into the youth, between ODD and conduct disorder, it's a pretty good number of youth. So there's a lot of value in figuring this out, so we can do something about it and preventive, hopefully going forward. So Monahan did a very large study many years ago now and showed some very interesting risk factors. Men in general are 10 times more likely to be violent in a given year. They usually look at a per year basis on these studies than women. But interestingly, when an individual has mental illness of a huge range, actually, what we used to call the Axis 1 mental illnesses in general, and some of the personality disorders, or intellectual or developmental disabilities, it seems to even out as though it has a bigger effect on women, and then the men and the women both are more violent than they would have been without the mental illness or without the intellectual or developmental disability. We also tend to know the next one, younger people are more violent. All of us perhaps were more impulsive, more potentially violent when we were 20 than when you're 40, and certainly then when eventually you get to be 60 or older. people just don't tend to be that violent as they get older. Now, maybe some of that's wisdom, maybe some of that's awareness that if you get hurt, it's going to take longer to heal, right? All the things that, both factors in your brain that may be unconscious even, but we just don't tend to be as violent. Instability of any type, sort of again for quick time here, increases the risk of violence. Alcohol and substance use, and I'll show you a better study on this in a few minutes, increase it. And then a history of violence, I have it in green here because that is the single biggest predictor of almost all human behavior, is that particular human's past behavior. So if Mr. Jones is violent every time he has a bad day at work and he comes home and punches the wall, you can pretty well predict the next time he has a bad day at work, he's going to punch the wall. Right. And unfortunately, this translates into people who have made a suicide attempt. They're more likely to have a suicide attempt. People that have punched other people are more likely to punch. So that really does follow suit. When I talk about this topic with medical students, I tell them, make sure you know that for the board exam because it'll be on there somewhere. Um, so just kind of boiling it down here, this is not crying wolf. The studies do say that if you say you're going to harm someone, and specifically if you say who and how, it's likely going to happen, and you really should take it seriously. Now, obviously, if it's the ninth time your patient has done this, then you start to question it. Then you probably also need a psychotherapist to work both with medicine and psychotherapy on this to figure out what's going on, that person's using this as the way of stating something, some information they're trying to get across. Again, here's that history of violence, alcohol, and substances. I mentioned impulsivity. So, interestingly, I found this very interesting. Studies of people that are driving reckless on a regular basis or tend to overspend, um, really without inhibition, even if they don't have the money to do it, so they run their credit card bills, whatnot. Those that greatly increases the risk of violence. So, if you get that information on your patient, you're trying to determine violence, that actually may give you a big clue as to their potential risk may be higher based on that fact. Psychotic illnesses do, in fact, increase the risk of violence. In general, we're talking about delusions. I think I have more of that on a different slide, more than hallucinations and so forth. And of course, that requires treatment for sure. By definition, you can't talk them out of a delusion, so you're going to have to work with them around that with medication and potentially psychotherapy to at least teach them not to share the delusion and air in with people that are going to have problems with that delusional thought. Um, I left it here as Axis One. That obviously came out of the DSM-5 starting in 2013. But the point is, the major mental illnesses, which in the research includes OCD and some others, not just in quotes schizophrenia, depression, bipolar, does increase the risk. And then certain personality disorders are known to show more violence. Antisocial, about 50% of people in prisons actually meet criteria for antisocial personality disorder. The other 50% don't, mainly because there's no evidence of juvenile delinquency. So, in order to have antisocial personality disorder, you have to show also the youth behavior that would sort of match the adult criminal behavior. And we don't always have that information for inmates in the prison. And then borderline personality disorder, of course. Organic personality disorder, really old term, but really what we're talking about probably is something impacting those frontal lobes in a way that we can't measure. And as I said already, that can increase the risk of potential violence. Um, Genetics, of course, so a family history of psychosis, the person might have a higher chance that there's something going on in their brain. Soft neurological signs, like so perhaps there was a head injury, very mild, you don't know it. They played soccer a lot. They were in a competitive sport where they were hitting the ball with their head a lot. Humans, when we're born, for example, have certain reflexes for survival. One of those is called the rooting reflex. So you brush the cheek and the head turns toward the side. That's for suckling. That we're built that way from a very early age to suckle, to breastfeed. That goes away as we get older, not even much older. It goes away pretty early on in life. That can come back if you have certain brain injuries. So you get a neurologist to test for a lot of particular reflexes. They may find that the person now has some of those back. That's a soft neurological sign. There's something going on that should not be there as an adult. Any of the illnesses that affect the central nervous system, obviously, there's a huge number of those that I won't go into, but those also have been shown to correlate with higher likelihood of violence. And then I've already said intellectual disabilities, developmental disabilities, and you'll notice the difference increase here, but they end up kind of equating. So male and female individuals, say with an intellectual disability, especially if it's moderate or severe, much more likely to be violent than their normal or average intelligence peers. Again, I'm kind of drilling down more and more through the slides here. So if you get into schizophrenia where they have paranoid delusions, that planned violence is very serious because again, the rest of their brain may be working perfectly fine. They're not disorganized. They can, in fact, direct their violence toward their perceived persecutor, and that's potentially hard to sort out, but very important to ask if you're working with patients. I know that like in the state hospital, and I see Dr. Stankowski on here. She's worked there for years as well. We see that, right? That was a place we had to always do those evaluations. Like what a much more detailed. Well, wait a minute. Let's ask some more detailed questions apart from, hey, are you thinking of hurting somebody? Well, no, that's not a good enough question when you're worried about releasing somebody who's got a history of violence. That's why they're in the hospital, et cetera. You need to drill down onto under what circumstances might they act out in a violent manner based on their perception. Um, Command hallucinations. This is a hard one. Anytime you see a study where a quote like this, 10 to 80%, that means there's a bunch of studies and they had a range. 10% complied, 80% tells you very little, is the point, right? The studies are all over the map, so I wouldn't hang your hat on that one. There is value in this if it's delusions, because those again are much more related to violence. If it's a familiar voice, so the person's brain has interpreted the voice as maybe their dead grandmother, or maybe potentially even God, or something like that. If they believe that's God's voice, they may be more likely to comply with those hallucinations. The best one again is past behavior here. If you know they've been violent in the past and they say it's because they were complying with their hallucinations, that's a bigger risk in the future. If they have command hallucinations, they may again comply with those voices, even though in general it's unclear how often people actually do that. And then again, delusions are huge here. Erotomania is a big one. Some of you are old enough to know about our famous David Letterman there. And you know, despite his money, he had for years had a woman who erotomania believed she was supposed to be with him, be his wife. And now generally these individuals don't harm the person that they believe they're supposed to be married to or in love with. They go after the person who's in the way. So they might go after the wife or the husband. And so she managed, despite all of his money, even to get into his house. I mean, that's how driven this delusional belief is in this erotomania. So very serious potential consequences for some of these delusions and the potential violence that they can bring. Other diagnoses, mania. People with mania don't tend to be violent of nature. They're not going out committing violent crimes in general, but their personal space is the size of a football field. So if you start to get closer to them, you are infringing on their freedom. They may perceive that, they may react to that. The violent limits, and we teach this to the law enforcement as well. If they start to move in on somebody like that, and for them that may be 21 feet away, and they start to move in, then that could be an issue for being careful about violence from that particular person. Major depression. Again, these individuals, the word that gets used is despair. And in despair, they may hurt themselves. They may hurt loved ones and themselves. They may set up a situation of suicide by cop. So lots of things can flow from a major depression that leads to the point of danger to self or others. And then I've already mentioned a bunch of these personality traits, so I won't spend a lot of energy on that now. Okay, situational factors. We've done some clinical factors. We'll do some situational. This is the instability. This is the violent environment, right? If they grew up with childhood abuse, that trauma, other types of victimization, maybe they witnessed their parents fighting or beating each other, right? All of those factors can play into whether the person was modeled. Violence is a way of living, right? Hey, mom used to punch dad all the time. Well, they grow up and that's normal. And in fact, they may even unconsciously seek out relationships where they end up in those kind of relationships where they're getting beat up or they're beating up. There's a lot of that repetitive over generations because of the modeling and everything else that goes on there. Also, a subject of lots of research. The violent peer group I mentioned, wilding being one of those types. No doubt weapons. If you look at data between the United Kingdom and the United States, the biggest single predictor of bad outcomes, for example, people who go to bars, is weapons. In England, you go there and you get in a big fight. Yeah, you may get beat up. You may even get knocked unconscious. In America, someone pulls out a gun, right? So someone's dead. So it's a very that greatly changes the playing field of the magnitude of the violence. What could be the outcome, and that's of course a concern for us in this country because we know that that is much more likely. And Ohio has fairly open laws around carrying guns now and stand your ground. So if you feel threatened anywhere in society, you can potentially pull your gun out and shoot someone legally, and so obviously that could be a higher risk for somebody who you're treating, so forth. And then healthy relationships, a huge issue. We know that COVID that decreased our ability to interact with others for a period of time. Most people had some decrease in that. Some had a huge decrease in that. Did not go well. And not necessarily increasing violence, but it certainly increased a lot of mental illness symptoms in many people, and so forth. So there's definitely something about not having these relationships that affects us. Childhood factors. Again, mostly these are correlated. These are things you might see. I'm very interested in prevention, obviously, of violence. So knowing these things in a youth would be very nice to deal with it as before they grow up, and in theory are able to stand on their own at the age of 18, especially in our weird systems where we often are able to provide a lot of resources to youth, and one day they turn 18 and magically they're in a whole new system. And of course, they magically say, I'm done with all of you. You've had me under your thumb for my whole life. I'm going to do it on my own. And they have no ability to do it on their own. I'm not sure I was ready at 18 to do everything on my own. And I had a reasonable upbringing. So, right, I mean, I think this is a problem that we need to just, again, pay attention to. So here's a huge study. I'm going to bring it home here soon, where they showed. So Swanson, who's actually still out there doing research, he's been doing this kind of research for many decades, obviously, since 1990. And I did round these numbers slightly just to make it easier to remember for you. But 90% of patients with mental illness are not violent. That's really the bottom line. I think that's very important to keep in mind. 2% of the people in the study was 10,000 or so individuals, so a very large study, very hard to pull off in 2025, but back in 1990 they were able to do this. And they evaluated every single person with scales and the like to figure out if there's any mental illnesses. So this was not self-report. This was a very good study. 2% of humans in the study were violent per year. Notice the five-fold increase, 10% with active, what used to be called Axis 1. So I listed them here because they're still the serious mental illnesses. Notice that even panic disorder and obsessive compulsive disorder were on this list. It's not just the big three, schizophrenia, depression, mania, that we tend to think about, or bipolar disorder if you prefer. Notice, I think this is very apropos for today's world and in all the laws around cannabis. It's a 10%. Look at, I mean, tenfold increase for those of us who are not that violent to using cannabis. That's nobody talks about that. So I think this is very important in our society. And in fact, Colorado and some other places that have had this for longer have seen increases in violence and so forth. It's not the old Cheech and Chong movies where they're sitting around laughing and eating Doritos and pizza. I mean, there are certain people with cannabis that it's a problem. Indeed, alcohol is worse. You'll hear that, oh, but alcohol is worse. Well, it is worse. Even in this study, that increases violence risk even more than cannabis. And then, of course, look at other substances. This study, 1990, predates the opiate epidemic, which by good accounting probably started in 1999, even though we didn't talk about it till 2010 or later. So that's in here too. A third of these individuals are violent per year when they're using other substances. So again, way more violence comes from that than comes from mental illness. So substance use is high risk. Finally, this is just a summary here. In general, the actual relationship between mental illness and violence is low. Uh, if, in fact, the person is violent, it's rarely against a stranger. These are not individuals running amok in the streets. They're hurting their mother, father, brother, whoever's in the household with them all the time. Excuse me, trying to help take care of them, giving them the support they need. And unfortunately, that's who gets harmed if a person with mental illness is violent. And it's only during acute psychiatric symptoms when treatment occurs, they go back to this 2%. So that's the wonderful part. If you treat them well with the medications and often psychotherapy as well, the violence goes back to baseline. So here's the Treatment Advocacy Center, big proponents of looking at a lot of things in the forensic arena, as well as a sort of outpatient treatment and other things. This is their quote that a small number of individuals with serious mental illnesses commit acts of violence, including 5 to 10% of all homicides. Right now, think about that. Of all the homicides, at most 10% are anywhere tied to mental illness. So the society doesn't see it that way. When there's a mass shooting, the first thing, oh, they were on Prozac. Well, so what? So is about 25% of the world on a serotonin, selective serotonin reuptake inhibitor. Literally, it's one of the most prescribed medicines worldwide. So it has nothing to do with the fact that they had a mass shooting, but that's what comes up in all the various newscasts and so forth. Um, and it also says that almost all of these acts of violence are committed by individuals who are not being treated. Again, if they were treated, they'd be back at that 2% baseline. And many of them are also using alcohol or drugs. Again, it's a slightly older quote because it still says abuse as opposed to misuse that we're trying to get into. So very, very important. So in a risk assessment, you're going to take all the threats seriously. You're going to look at lots of factors here. Again, I won't spend a lot of energy for time's sake. We can come back to these if there's time for questions. Um, there are standardized instruments. I did want to mention that. A lot of these are actuarial, which is kind of the word they use for insurance or that kind of stuff, risk type things. There's algorithms. They're very objective. So here are some of them. Again, this is going to be another 2 hour talk. But the HARE, HARE, was the person who created the first one, psychopathy checklist. There's the HCR20, which I think gets used the most. It's now in the third version. I think the state hospitals are using that. I know CSS has been using that as well in Summit County, where they get the individuals who come out from the state hospital on conditional release. So those are the big ones, but there's others, the VRAG and a bunch of these other ones here. Um, Very good, but not alone, because those alone cover like historical, you can't fix those, static, can't fix those either, dynamic risk factors, there are clinical, excuse me, risk factors. Uh, so they may actually overpredict violence, and they don't capture, very importantly, the protective or mediating factors, right? So that's another piece, and they also take hours to administer, which is time is precious in our clinical arena nowadays. It's very hard to do that. So review all the risk factors, and guess what? We're still not very good. At most, our predictive power, if you can even predict at all, is 24 to 48 hours. Too many things intervene. You can't expect that, right? You might see the person for 15 minutes out of a month or out of every 3 months if you're a psychiatrist, or maybe if you're lucky, 50 minutes, the old 50-minute hour once a week. It's a lot of hours that you're not accounting for where things happen. Life happens. You can't, so we're not very good at predicting. It's like meteorology and the weather, right? So the weather says it's going to be X. Well, then a new pattern changes somewhere else in the world. The old butterfly effect, the butterfly flaps its wings, and the forecast gets thrown off. And you need to take that new information into account to really make a better prediction. So very difficult, right? You really have to do this, and we do tend to err on the side of caution. So clinicians do tend to overpredict as well to make that happen. Oh, and actually this is redundant because I pulled this quote out. The rest of it is the same. And even with all that, it's sometimes hard to predict who might be violent. I'll let you figure out what the last slide means. So, all right, I will take questions. And I know that was lightning fast, but time is of the essence for these echoes.